So acute anterior uveitis is probably one of the commonest problems that we face in the clinic, and the one I see residents running away from. Even senior consultants would just dump them on any uveitis specialist around in order to get out of this puzzle of solving the anterior uveitis. First of all, it is always a query. What is the possibility? Second of all, which makes it irritating, is the number of times that you have to see the patient. And oftentimes these patients are chronic patients that will not leave the clinic very soon. Even after treating them for several years, you know that they might come back to you someday. Third point is sometimes you have to break bad news to the patients, and taking care of the patient's psychological aspect and management side effects needs a lot of political approach and a lot of wiseness and reading, plenty of reading to make sure that you are not missing things. This is what makes uveitis a little challenging specialty than others. But I'm sure that no one has entered ophthalmology unless they are good in medicine. So probably uveitis is the medical part, just like retina, where you can be attached to medicine in direct connection. Anterior uveitis is the term used for the group of inflammatory disorders for which the preponderant part of the inflammation is situated at the level of the pars plicata of the ciliary body, the retroiridial space, and the iris and the anterior chamber. So any inflammation anterior to the pars plicata is called an anterior uveitis. Sometimes we have anterior hyaloid vitreous cells, which we call them spill over to the anterior hyaloid, but this does not mean that the patient has vitritis. There is a little subclassification that you will read in the textbooks and see that there is something called iritis, iridocyclitis, and cyclitis. This is just a distribution of cells count. If the cells are more in the anterior chamber in front of the iris, they call it iritis. If the cells in front of the lens and behind the lens, and this is in the anterior hyaloid, are equal in number, we call it iridocyclitis. But if the cells were mainly in the anterior hyaloid, and I mean by this, it does not reach the midvitreous, it does not reach the back of the eye, and little of them are in the anterior, this is what we call cyclitis. However, by epidemiology, anterior uveitis may account up to 90% of cases of uveitis. Most of them are non-granulomatous uveitis, and 83% have non-infectious etiology. Now, these epidemiological reports are based on Western population and not on our population. The male to female ratio is a little in the favor of females, where they have more, 1.5 times almost more than males. Children usually present with a silent disease, where juvenile rheumatoid arthritis can be the main cause. Young adults, according to the ethnicity and distribution, would be like Paget disease and HLA-B 27 associated uveitis, Fuchs uveitis. In older patients, that is more than they're in 20s and above, would go with VKH, herpes, and TB. And this again depends on the ethnicity. In comparison to the papers published at in Saudi Arabia, there was one by Professor Tabara in 2007, who found that anterior uveitis accounted for 60% of the cases at his center, while panuveitis came back to be 24%. Similar results were by King Abdulaziz Hospital. In fact, not really similar, they were the opposite, where panuveitis was the commonest. I don't have it here, but panuveitis was the commonest presentation. And I think this is because of the difference of their subspecialties. Now, what could be the etiology? How can I classify acute anterior uveitis or anterior uveitis in general? I can go to the cause and I can go to the presentation, the pathological presentation. So if we will classify it according to cause, there are these that are HLA-B 27 associated diseases. There are the infectious etiologies, but again, the anterior chamber has its own characteristics where things can be related to the lens, patient's own lens. For instance, a trauma to the lens that has caused Rupture in the capsule can cause lens-induced cataract, lens-induced uveitis, or those who have had an hypermature cataract that is self-resolving, and it can also cause a chronic inflammation and uveitis. Those who are already pseudophakic and may have IOL related, if the IOL is placed in the sulcus with rubbing surface on the iris, or if the patient has a CTR in the sulcus, maybe rubbing on the iris as well. Those patients have to have a certain dilated exam to make sure that everything else is normal, along with ruling out P. acne related chronic inflammation. Some patients post-trauma, we all know that traumatic cases have their own differential diagnoses like traumatic iritis, hyphema, iris dialysis, iridocorneal touch. Trauma by itself is a 2-day lectures probably. The idiopathic ones are the last to be thought about when you rule out malignancies or cases that are masquerading. Now, if we are going to follow the standardized uveitis nomenclature, make sure that you know what is a limited duration. This is if the inflammation is less than 3 months, and it's persistent if it's more than 3 months. It is acute when the presentation is sudden and less than 3 months. Recurrent when it is repeated episodes separated by periods of inactivity without treatment for 3 months. And it's chronic when it is persistent and relapsing in less than 3 months after discontinuing treatment. Now, in uveitis, you need to think about everything. You need not to take things for granted from the patients and look for clues. Once the patient enters to your clinic, your time is to ask about the unspoken history. What is so peculiar about this patient? What this patient thinks is not related to his disease, and you know that it might be related. Ethnicity, gender, travel, and age. These are all important for us. How is this patient's social history? A fan of pets, drug abuse, and I mean here, I don't only mean bad pattern of drug abuse. Drug history is very important to know if the patient is taking any medication that can cause uveitis. We all know that some treatments like topiramate, moxifloxacin, anti-epileptic medication can cause uveitis. Raw milk ingestion for brucella in our population is important, and direct contact with pets and fecal matter of pets is also important to know. Travel history, we know for certain, طبعا alhamdulillah, last year I don't think anyone has traveled, but we know for sure that some diseases are predominantly present in certain parts of the United States. Like, you know what this is? Anyone knows what this is?
Lyme disease?
Yes, ahsant. And this is by tick bite, the female tick, not the male tick. Leprosy, and you can see here by the geographic highlights where is it still predominant. And who knows what this is? Onchocercaria, that lives in livers and transferred by fly. So all of these has to be ruled out in your history. I will not go through the classification again. We all know this. What are the common symptoms? We all know that they present with pain, redness, photophobia, blurring of vision, headache, recurrence, or it may be asymptomatic. But let me here highlight that the patient may come to you, especially those educated patients, a little earlier than any sign on the slit lamp. And that is when they say, specifically, I have pain in my eye when I read or when I strain. Now, you rule out the presence of hyperopia and the visual disabilities, but when the patient comes to you of one eye pain during reading or during near vision, it means that this patient is having a lot of strain on the ciliary body as it is accommodating. And this can be the very earliest symptom preceding any inflammatory cells in the anterior chamber. This is a paper that I would recommend for you to read. It's a little old, but it has a lovely approach by Dr. Carl Herbert, and I will be speaking about it now in the coming few slides. And I'm sure you all know this common slide of mine. I don't want to put a lot of time on it. You've all seen it during the basic science course. However, in quick, the conjunctiva, when patient comes to you in the clinic, make sure that you examine it under direct light before putting the patient on slit lamp to see the pattern of redness. Is it diffuse, sectoral, 360 degrees, nodular, non-nodular? All will appear before putting the patient under the slit lamp. Look to the cornea and the corneal clarity, haze, and sensation. Anterior chamber cells, flare, and hypopyon. Iris, we'll be talking a little in details about it in a few minutes. And the lens for the presence of posterior subcapsular cataract, whether it is from the treatment, steroid induced, or from the disease itself, like in Fuchs. Make sure you are not missing a vitritis or vitreous hemorrhage. Make sure this is only anterior segment uveitis, not posterior, by dilated fundus exam, looking carefully to the blood vessels, choroid, retina, and tracing all the 8 corners of the retina. Pars plana is so important because it's often missed, and you cannot examine it without real dilated fundus exam or 3-mirror examination. Now, if the conjunctiva, I mentioned here, you can see here that there is the ciliary injection. This is almost 360 degree, and it does not spare other angles. In this second picture, it's only sectoral. In here, we have what we call like a nodule or a scleromalacia, where it is the sclera has already thinned out to show the choroid underneath. Signs of anterior uveitis on the cornea, the keratic precipitates, corneal edema, and in chronic cases, the band keratopathy. Now, keratic precipitates are not that simple. There is a lot to speak about, and I'm sure you already know about it more than I do because I always ask this question for all the residents. They are cellular deposits on the endothelium. Fine KPs are presumed to be of non-granulomatous allergic type, and they are from lymphoplasmocytic inflammatory cells, while larger KPs that you can draw anything more than a dust is called granulomatous, and they are of epithelioid cells. When you want to assess KPs, I need the size, color, shape, and pattern of distribution. So, sorry, now here. Yeah. If it is a dust-like, then this is called non-granulomatous uveitis. This one is the microgranulomatous. This is a medium size, and this is a mutton fat KP. Sometimes they call these two as mutton fat KPs. I like to distinguish between them because for the future, we still learn what is going on in the patterns of uveitis. The first one is non-granulomatous. It's just like dust, and it's usually pigmented, whether it's stellate or non-stellate. The microgranulomatous, medium and large are all granulomatous KPs. This is a little table to show which pattern of KPs you would see in each disease. In Fuchs uveitis, we have them stellate, plus minus, but they are usually distributed all over the cornea. There is no selection for one certain corner of the cornea. In CMV, they may be grayish to light brown, and this is very peculiar about CMV. They are not really white KPs, and usually there are not plenty, 1 or 2. In other papers, there is a new paper published, Demystifying Viral Uveitis, presents 6 patterns of different KPs for CMV uveitis. And I have a link for this paper for you to review. In herpes simplex, usually they are also light gray to brown and usually located in the center. They are not in the periphery. In CMV, they are mostly in the periphery. Sarcoid and TB can be like VKH, that is mutton fat, large, and distributed in the center or in the lower half of the cornea. Postner is related to CMV, and we will find 1 or 2 KPs in the far periphery with high IOP. These are the pictures of the different KPs. So the first one, Herpes Zosterophthalmicus or cytomegalovirus, anterior uveitis, scarce unilateral KPs of different sizes and small to medium. The second will be motton fat KPs, this type of gravitational large TB, large as in TB, sarcoid, toxo, and birdshot retinopathy. These are the fine dusts that you see. They are still granulomatous. We don't call this non-granulomatous for those who are confused. This is still granulomatous. And look for the other subtle signs like this here, iris atrophy, sectoral you see with HSV. Now the iris. Once you see the iris, please, the way we were taught in medical school, when you examine the knees or the elbows or the joints, how you compare both, you need to compare both eyes. You might miss the iris findings if you don't compare the two eyes together. In this eye, you will see the diffuse iris depigmentation. Here you can see how it has lost its dark color. And the troughs here are still present, but with time, they become lost. Now, whether it is hypochromic or hyperchromic, in our population, because we already have dark irises, once the stroma is thinned out, what will appear is the back surface of the iris, and we will look hyperchromic. It is the opposite in lighter eye population. Then you have to check for the corneal sensation, and I do this either with a Q-tip or with applying binoxynate. Once you apply the binoxynate, the patient will tell you, it burned me in this eye, it did not burn me in the other eye. This is what I use in the clinic. There are other materials like aesthesiometer or using a dental floss string, sterile one, or any soft tool, sterile, clean. Make sure that you don't use the same tool for both eyes. Each eye should have its own testing cotton. Checking the intraocular pressure, and this makes a difference because either it is high or low. Most of the non-granulomatous uveitis will present with low IOP, and most of the granulomatous uveitis will present with high IOP. And we'll see in the coming few minutes the difference between them. This is a FLAIR photometer. This is the anterior chamber cells. And what you see here with cells, you need to make sure that you count only the white cells, not the pigment or the hemorrhagic cells if present. This is how you see the FLAIR and the cells together. And this is a subjective measurement by the slit lamp. Again, you can look to the angles using a gonio to see if there are any settling remaining cells, especially when a patient comes to you already on treatment or referred from another colleague. You need to do gonio. They usually stagnate on, with gravity on the inferior part. So don't miss it by doing gonio. If the cells are less than 0, we call it 0, or up to trace cells, this is less than 5. When it is 1 plus, when it is more than 5 to 6 to 15, 16 to 25 is 2 plus cells, 26 to 50 is 3 plus cells, and more than 50 is 4 plus cells. Now, the residents often come and ask me, do you actually count the cells? I say, yes. I put my slit lamp at 1 millimeter, and then I angulate it. It has to be the highest magnification I have on my slit lamp, and with the highest illumination. And I actually count the cells. I usually put it in the center with a black shadow behind it to count the cells. This is a laser flare photometry that has the only machine that measures the amount of flare, and it helps as taking it in the primary visit and in follow-ups. It's a good method, useful for titrating your medication, especially when your patient is asymptomatic. Now, what do we see in the iris? Heterochromia, iris atrophy, posterior synecdoche, iris nodules. And just to remind you that the Bosaka iris nodules are usually on the iris stroma, and the Coppe nodules are on the pupillary margin. The Coppe nodules may be the beginning of a synecdoche, or when they resolve, they end up with a synecdoche. So when you see a Coppe nodule, if you are keen to observe your patient, or if the patient did not medication and you follow him soon enough, you will find at the edge of this, where the Coppe has disappeared, a synecdoche has formed. That's why Coppe nodules may present in both granulomatous and non-granulomatous uveitis. but Busaka are usually in the granulomatous uveitis cases. This is not, here just to remind you that this is only leash nodules and they are not iris nodules. Does anyone know what these are? Has anyone noticed them before? These are called Russell bodies. They are small rectile crystals and they are peculiar for Fuchs uveitis. Pay attention in the future visits of patients who are diagnosed with Fuchs, especially when they are asymptomatic and not on medication. You might find these crystal-like material on the iris. The synecdoche can be so aggressive that it can cause Occlusion Pupil, like here, 360 degree, and this will cause iris bombae. Always check for the IOP when you have such a thing, because this will tell you if the patient has got, if it has high IOP, it means you need to do a PI, and this gives you a clue that the ciliary body is still functioning. But if you see this picture and no PI and the IOP is low, then most likely this patient has got a ciliary body membrane or cyclodialysis cleft, and the patient's prognosis for vision here is low. A membrane on the pupil is what we call occlusion pupil. Notice here that there is no adhesion. This is just from chronicity, where flare or chronic inflammation has caused this membrane. And usually they don't have high IOP. If it's open, but if it is associated with NVGs and NVA, then it will be neovascular glaucoma. Now, iris atrophy can be different from one person to another. It may not only look as a diffuse iris atrophy, it might appear as an asymmetrical pupil. In this case, the pupil is peaked to the right, and you see that the atrophy is here. All of this is normal as the pupil is trying to constrict. The muscles here are normal, while here, all of the muscles are lost. The pupil cannot constrict to its normal position because the muscles are lost. And this is called a sectoral atrophy or peaked pupil, where there is only one quadrant or one corner of the iris is not apparent. Sometimes the patient comes to you and it's not apparent. When you dilate the patient, or on the next visit where there is no dilation, you will be able to see it. This is يعني خلينا نقول انها توضحت بعد dilation, or it became more apparent after you do your dilated fundus exam. Fibrinous clot in the anterior chamber, which is very common in HLA-B associated uveitis. And this is where a broken synecdoche, you can see here, all has happened after your treatment, successful treatment with dilating drops. One of noteworthy here is this case published about diffuse iris transillumination and loss of iris pigmentation after the use of systemic moxifloxacin. That's why drug history is important in cases that present to you. I have a female colleague here in military hospital who presented with bilateral acute non-granulomatous uveitis after using antifungal treatment. So drug history is not to be overlooked. Rubeosis iridis comes in severe in chronic inflammation, especially when not treated, and can be very bad in causing high intraocular pressure. You need to look for signs of chronicity on pupillary margin and with uveitis. Usually it's reversible if you treat and you control it. And you have to rule out other causes of ocular ischemia. Now, what about the non-granulomatous anterior uveitis? So we'd like to mention here that it is mainly related to HLA-B27 diseases like Behçet. Juvenile rheumatoid arthritis is not an HLA-B27, of course, and Behçet is not an HLA-B27 related. It can be also uveitis associated with scleritis or with tino, like in kids, or streptococcal infection. This is chronic streptolysin O infection in kids. It can be drug-induced or after surgeries, but not with sympathetic ophthalmia, of course. HLA-B27 is a gene that is responsible for encoding the class 1 major histocompatibility surface antigen subtype B. Its main function is to present the antigen T cell and thus triggers the immunity cascade. In Caucasians, it is 8%. In North Africans, it's 4%. Chinese, 2 to 9%. Japanese is almost half. And in Scandinavian, it's 24%. So when I tell you this patient is HLA-B27 positive, do I mean by this is the patient sick? No, it is not. It is just that I'm telling you what is his immunological pattern. HLA-B27 is not a disease, it's a pattern. It's exactly like saying this patient is tall, this patient is thin, this patient is white, this patient is Caucasian, this patient is black. We know by default that white patients are more prone to have, for instance, ultraviolet light induced skin cancer, while black patients do not have this. We know that dark skinned patients are prone to have keloids, while white patients will not have keloids. This is their pattern. Now, having known this makes me understand that patients whose immune pattern is HLA-B27 positive are more likely to develop some certain diseases. It is a gene, and you cannot change it. All patients, most of the patients with HLA-B27 are not sick. They are actually healthy patients. But if they have it, as I said, positive, they are prone to develop some sort of autoimmune disorders. Why? It is because of an environmental factor that can trigger a certain cascade of immunity, especially when this environmental factor is a microorganism, especially gram-negative bacteria. Now, about half of all acute anterior uveitis cases are HLA-B27 associated. So 50% of your cases presenting to the clinic will be HLA-B27 related. And this is epidemiological related to the West, not to our Middle East. We do not have this in the Middle East clear epidemiological studies. 50% with acute anterior uveitis and HLA-B27 positive will have spondyloarthropathies, while 25% with HLA-B27 positive patient, if I have a population, if I have 100 patients who are 20 HLA-B27 positive, 25% of them will develop acute anterior uveitis at some time of their life. واضحة الآن؟ ألو؟
نسمعك دكتور.
طيب واضحة الفكرة. I want you to understand this, that if the patient has normal patient has 20 B27 positive, out of 100 patients, 25 or quarter of them will develop uveitis at some sort. If they already have uveitis and they are B27 positive, half of them will have a spondyloarthropathy. Okay? HLA-B27 is the strongest known genetic risk factor for acute uveitis. An ophthalmologist may be the one to diagnose a systemic illness. Acute anterior uveitis may precede symptomatic patients many years before. I have a patient who I've been seeing every now and then. She comes to me twice a year with anterior uveitis, very subtle. She disappears in 1 or 2 weeks or with minimum steroids. And after 6 years, she developed the signs of ankylosing spondylitis. She never complained of anything until 6 years later. So make sure that you do not miss referring them to a rheumatologist. However, HLA-B27 negative are often the ones who are missed, and we'll see in which category of patient. Now, spondyloarthritis, this is a group entity of diseases. It's an umbrella that covers plenty of diseases. We know ankylosing spondylitis, Reiter's, psoriatic arthritis, inflammatory bowel disease, Whipple's disease, reactive arthritis, and undifferentiated type of spondyloarthritis. These patients have rheumatoid factor negative and commonly are young males. And the trigger, if you go back in history, they will either have a severe gastroenteritis at some time recent or UTI. You need, when you want to work these patients up, you need to determine the severity of Sells flare and hypopyon. You have to do a dilated fundus exam and determine the patient's age, gender, race. We know that patients with B positive have these diseases, and negative are usually Bahjat patients. In children, however, we need to rule out GIA with ANA positive, TINO, and to rule out TINO, you have to do urine analysis looking for glucosuria and dosage of beta-2 microglobulin, which is found to be elevated in TINO. So this is non-granulomatous uveitis. No one will do for urinal biopsy, but this is written in text. Teenagers, again, GIA, TINO, and here you have to include B27 and B51. Adult males are more prone to develop Bahjat and Ankylosing Spondylitis writers, Herpetic Eye Disease as well. In females, Herpetic Eye Disease, and in recent studies, Ankylosing Spondylitis, females and male are always equal. Now, what are the characteristic features? It's often unilateral, no KPs may be seen, only dusting, marked proteinaceous extravasation if the patient came to you late or without treatment before proceeding to you. Flare and cells are very predominant, and you can also see hypopyon. This table you can take picture of what is the commonest presentation for each disease. In ankylosing spondylitis, it's acute uveitis and scleritis. Writers, conjunctivitis and uveitis. Psoriasis, again, it is very mild uveitis, dry eye, keratitis. Inflammatory bowel disease is a little different, where they can come with scleritis and episcleritis, or PUK. Undifferentiated spondyloarthropathies, it's just where we call it idiopathic uveitis. Ankylosing spondylitis is a disease that is diagnosed mainly radiologically. Patient may come to you early without any signs systemically. However, they will have positive HLA-B27 and radiological findings. Before, in all textbooks, it says male more than female, but now it is male and female are equal. It's more common in white men than Black and Asian men. This is how a normal X-ray would look, but on MRI, you will see that there is enhancement in the sacroiliac joint. So always refer patients for sacroiliac MRI with enhancement. Again here, this is what you see on T1, weighted post-contrast images, enhancement of the contrast media at the border of the lesion, revealing acute spondyloarthritis. It's here. Cannot be seen by regular X-ray. Now, the American Society of Ankylosing Spondylitis classification criteria, you need to notice that one of the clinical features is uveitis, as in here. So whether the patient has an imaging positive or one of these features, or HLA-B27 positive and on two or more of the features, then the patient is diagnosed with ankylosing spondylitis. So what are the factors that increase uveitis development? If the hip joint is involved, this is a high risk of developing uveitis. So ask by history. If the patient comes to you already diagnosed with ankylosing spondylitis, ask if the patient's hip are involved. If higher titer of anti-streptolizin O, or if there are high levels of circulating immune complex. All these factors will increase the risk of developing uveitis. I can't see, I can't pee, and I can't climb a tree. These are the triads of what? Who would like to answer? Okay.
Writer disease.
أحسنت يا دكتور. Yes, this is most likely Writer's disease. Writer's syndrome, we call it, because it has plenty of features. Geographical tongue ulceration, keratoderma blenorrhegica. This is a brown aseptic abscess on the palms and the soles. There are few diseases that affect the palm and the soles. Syphilis and Reiter's are one of the two things that are peculiar to have them. And once the palms and soles are involved, this is the first thing to rule out. It is non-gonococcal urethritis, arthritis, conjunctivitis, cercenet balanitis, Achilles tendinitis, and plantar fasciitis. Aortic incompetence can be in 2 to 5% with aortitis and aortic regurgitation. So patients with this is one of the common questions. You need to refer them to a cardiologist and do echo to rule out aortic incompetence. And the classification or diagnosis has to include an MRI scan. It is triggered by chlamydia, mycoplasma, and Yersinia. In HIV patient, you need to know that it is not related to HLA-B27. So patients with Reiter's syndrome and HIV might have negative HLA-B27. Okay. One last thing you need to know that arthritis is asymmetrical in them, and the sacroiliitis may be asymptomatic, and you will only diagnose it by MRI. This is psoriatic arthritis, and it's often missed because patients may not correlate their joint problems to their eye disease. Of course, these are pictures of advanced cases, what we call dactylitis, tendinitis, and enthesiitis. This is where you see the insertion of the tendon and at the calcaneum, causing inflammation and pain, and plantar fasciitis as well. These patients have HLA-B genotype positive, but not all of them, only 40 to 50% of them. The rest are HLA-B 27 negative. So they are often missed. Other symptoms can be like what you see in the skin manifestations, onycholysis of the nails and swollen red tendon joints, as here, psoriatic nail pits. I'm sure you all remember this in your from our medical school. Now, what are the risk factors for developing uveitis? This paper by the Casper classification of psoriatic arthritis. Mild psoriasis will increase the risk of uveitis by 1.5%, 1.5 times. Severe psoriasis, skin psoriasis, will increase the development of uveitis by 2 times. Psoriatic arthritis, if there is already joint involvement, will increase it by 3 to almost 4 times. When you have spondylitis, and then the risk increases to almost 9 times. Inflammatory bowel disease is another common extraintestinal symptom, would be episcleritis. Episcleritis is related to the disease activity in Crohn's disease, but not in ulcerative colitis. I'm sorry, it should be here ulcerative colitis, not keratitis. So acute anterior uveitis is usually bilateral in these cases, insidious and severe. It is not related to disease activity in ulcerative colitis, but it is related to disease activity in Crohn's disease. So Crohn's disease, both episcleritis and anterior uveitis, if they are active and the patient has Crohn's disease, then this is related to the disease activity in general. If the patient presents to you with a diagnosis of ulcerative colitis with acute pain and discomfort and acute uveitis, tell the physician, the treating physician, he might need to reconsider the diagnosis, that this might be a Crohn's disease, not ulcerative colitis. Okay, now I'm sure I've spoken to you before about the duet paper or the Dublin Uveitis evaluation tool. This is something presented in 2017, where an approach has been changed for referring patients to a rheumatologist. In the previous, when we were students, we were told that treat anterior uveitis first and second and third time, and do not refer them unless the patient had more than 3 attacks per year. Now, according to this paper, if the patient was not referred to the rheumatologist from the very beginning, you might miss patients with seronegative arthritis and HLA-B negative tests. This is a summary for you, if you can take capture of it. Anyway, it's in general, it says here that any patients with joint pain, lower back pain, HLA-B, whether positive or negative, acute anterior uveitis has to be referred to a rheumatologist from the beginning, and do not wait until you have recurrent attacks. Always provide patients with handout if they could not go to see a physician, and it is wise to do MRI scan of their joints that are in symptomatic. This is one of the fast algorithms written by Dr. Carl Herbert. In general, I find myself following them. If the patient has non-granulomatous uveitis and it's a child, do a bilateral, you need to make sure it's not TINO. If it is ANA positive, rule out GIA. Patients who are HLA-B negative antigen, adult patients should always have HLA-B screening. If positive, make sure to know which disease it is. If negative, and the patient is getting recurrent attacks, you have to refer them to a rheumatologist to rule out psoriatic arthritis. Granulomatous uveitis is another disease where the main cause now is viral. Now, 90% of granulomatous uveitis is caused by viral etiology, whether Fuchs syndrome that is caused by rubella, Fuchs-like syndrome that is caused by CMV, Postner syndrome that's caused by CMV, HSV, VZV, CMV alone by itself, Toxoplasma, TB, syphilis, EPV, and P. acne. Others where the disease can be bilateral, like MS, and chronic recurrent anterior uveitis in VKH, drug-induced, sometimes can be granulomatous uveitis, as in the case of topiramate medication. This paper that I hope you all read is Demystifying Viral Anterior Uveitis. It's a very good paper, so detailed, and it has a very nice table. I will give you a little bit tips about it, but make sure you all read this review. So acute granulomatous anterior uveitis is usually unilateral and recurrent with or without systemic association, and most of the patients are immunocompetent patients. How do we work them up? All patients, again, should have dilated fundus exam. I like to do fundus fluorescein angiography baseline for my patients. You need to rule out Fuchs uveitis, where again, I have to emphasize that Fuchs is a granulomatous uveitis, not a non-granulomatous uveitis. It has stellate KPs over the cornea, all over the distribution, all over the cornea, iris, loss of iris crypts, hypochromia or hyperchromia, depending on the ethnicity, no posterior synechia in Fuchs, and no macular edema. You need to also rule out a common cause, that is toxoplasmosis, using dilated fundus exam, serum IgM for active disease. Sometimes you have to do vitreous biopsy for PCR to rule it out. TB and sarcoidosis are other causes to be ruled out, doing AC levels by serum lysozyme level. Polyclonal antibody activation is present in up to 85% of patients with sarcoid, PPD, quantiferon test, and viral serology. Syphilis and Lyme disease, according to the travel history, we in Saudi Arabia, we do syphilis as routine. Fortunately enough, during my work, I have never encountered a positive syphilis case until now. Herpetic eye disease is overlooked, and it's a great mimicker. You may do PCR, but clinical judgment is yours sufficient. I have tried myself doing PCR. I was not lucky with the labs that I send them the results. And it always says the sample is insufficient because it needs special amplification. However, PCR is an aggressive test to do if your patient is suffering from, taking a sample is not quite risk-free. Sometimes, if I am in doubt, I might give my patient trial of oral antiviral and give them the benefit of doubt and see how they behave. This is one patient from the paper I presented a while ago, a 30-year-old following uveitis and often decreased vision and persistent floaters. What you see here is the stellate diffuse KPs, posterior subcapsular cataract, iris atrophy, and this is how the patient looked like after cataract surgery, where the iris has, all of the iris tissue is lost, and what you see here is the back of the iris epithelium. Now, Fuchs uveitis is mainly caused by rubella. And this is the one described in the literature long ago. So what we see in Europe and West is the one caused by rubella. Most of the cases are between 20 and 50 years of age. There is no gender predilection. The IOP is variable, but it is in the lower, not too high, not above 40. Usually IOP is high, like 30, 35, but does not reach to 40. You will see the stellate KPs, diffuse distribution. It is never pigmented, always white KPs. The endothelial cells are normal, corneal endothelial cells is normal. There is diffuse iris atrophy. Heterochromia is more evident in light-colored patients. There is no posterior synechia, as I mentioned, and there is always, most of the time, 50% of the time, posterior subcapsular cataract. If it is CMV induced, and this is what has been published now from the East in Japan and China and Singapore, where they have been doing PCR for Fuchs uveitis and found that most of their cases are related to CMV, and it is not rubella as mentioned in the West. So CMV can present in a Fuchs-like picture. The only difference here is the cataract is the main presentation in them, and their IOP is a little higher. Here, the KPs can be slightly different, where they are coin-shaped like distribution. I think I have a picture of that in a minute ago. This is the fine KPs, sectoral iris atrophy, peaked pupil, another example where the iris is not symmetrically, not diffusely involved, and that's what we see with HSV. In VZV, or varicella zoster ophthalmicus, I'd like to mention here that not all cases will have positive Hutchinson sign. Sometimes the patient would have the inflammation months ago and come to you with an eye inflammation. So ask about history of الحزام الناري or varicella zoster infection that even in the past few months, because this can come as a later presentation. And for those of you who have seen this or not, this is what we call nummular keratitis. I have a cousin who did LASIK. After 3 months after LASIK, he presented to me complaining of blurred vision. When I saw him, I found this. I was still, I think, a second year or third year resident, and I had to refer him to Professor Tabara. And he highlighted that this was nummular herpes zoster ophthalmicus. And from that day on, I realized that sometimes refractive surgery, especially LASIK, can be a trigger factor for viral keratitis, or it can reactivate viral keratitis. Usually the pressure is higher than HSV, and it has more vitritis than what you see in HSV. Now, mind you, both cases can happen in immunocompetent patients. They don't have to be immunocompromised to develop HSV or VZV. The difference between them in treatment is usually in varicella zoster, the dose of medication is doubled from that of HSV, whether you use acyclovir or valacyclovir. Pred 40 is to be tapered slowly and to watch intraocular pressure to reduce corneal haze. You have to give them Pred 40, but you cannot give them Pred 40 without keeping them uncovered by antiviral medication. Daily long-term treatment of once dosing either acyclovir or valacyclovir reduces the recurrence rate, okay? But watch for cataract and high IOP. Postner is the tricky disease because Postner was previously described as of unknown etiology. However, right now, after long-term studies, it has been related to cytomegalovirus. Postner affects patients between 20 and 50 years of age, mainly male patients. Keratic precipitates are always present. Attacks resolve spontaneously in 2 to 3 weeks, and recurrence is common. The patient comes to you with blurred vision just because the pressure is high. They don't have to have vomiting and nausea and severe headache, but they definitely come with severe discomfort. This is how CMV can present. You can see there are these 6 patterns of KPs that are different from one another. This is 1 or 2 large or medium-sized, or let's say microgranulomatous KPs in the center. These are more distributed in the sector, in a sector fashion, inferior part of the cornea. This looks like Codadus line. This is clumping. And this is what looks like a print, or what we call it like a rare print. So I will leave this for you. I would like you all to capture this slide before I go along, because it has an explanation for every pattern of CMV KPs, how they are different from one another, and they can all give you a clue. This, I think, is one of the trickiest, because most physicians would think that this is inactive old inflammation, probably the corneal dusting, but the accumulation here and the corners makes it peculiar for CMV. This as well, like a target lesion, will also link you or give you a hint that it is CMV. Now, if I'd like to ask questions about Postner, what is the most likely cause? It will be related to CMV. Is Postner caused by CMV? Is all Postner caused by CMV? No. Studies varies from 20 to 75% global variation. What clinical signs suggest CMV positive Postner? Here are the signs. Corneal endotheliitis with cone-shaped lesion. Linear KPs similar to rejection line, more common in males, resistant to treatment with topical steroid, may have synecdoche and diffuse iris atrophy. What risks does CMV positive Postner add? Risk of glaucoma and endothelial cell loss. When should you do PCR? When the patient is unresponsive to treatment. Okay. Now, how would you manage these cases? You have to control IUP. Start with topical steroids. If it worsens, it doesn't respond, give topical Valgan cyclovir 2% 6 times daily. If no response, do AC-TAP for PCR. Start oral Valgan cyclovir for 3 months and monitor white blood cell level. You have to control intraocular pressure by either medication or trap. Note, recurrent attacks can cause visual field dysfunction. So even these subtle inflammation that goes without visiting the physician may be affecting the patient's visual field. So you have to have a baseline visual field and nerve fiber layer OCT, and this is what you should be asked about in the exam. Give prophylactic anti-glaucoma medication to make sure that the patient will not have future affection of his optic nerve fibers. Okay, this is a little table to let you differentiate. So the main causes of viral anterior uveitis is Fuchs-like or Posner-like. In Fuchs, it's either rubella or CMV. In Posner, it's either HSV, VZV, or CMV. You can capture this slide as well because it is useful. This is my approach, and it has nothing to do with the publications, but that's how I look at my patients. So viral anterior uveitis is 90% unilateral. If there is corneal stromal haze, diffuse, I would think of HSV. If it's nodular, it's VZV. I have to check for the corneal sensation, which is not always present. If the IOP is high but below 40, I would think of HSV, VZV, and rubella. If it is above 40, think of CMV. If KPs are wide, small, diffuse, I would think of Fuchs. If medium size, go for CMV. If coin-shaped, I would go for CMV. Now, what is peculiar about each, some special certain findings? If there is hemorrhagic hypopyon, I would go with HSV. If there is vitritis, I would go with Fuchs. If there is endothelial cell loss, it's CMV, HSV. Or if there is skin lesion or history of skin lesion, I will have to rule out VZV. Now, the rest is the medications that can cause induce uveitis. I would mention here that topiramate, moxifloxacin, ibuprofen are the commonest ones that we are using, and this again has to be captured and take detailed drug history, please, from every patient coming for you with uveitis. How do you manage them? First of all, you have to relieve pain and photophobia, eliminate the inflammation, prevent structural complications such as synecdoche, secondary cataract, and glaucoma, preservation and restoration of good visual function. The number one drug is topical steroid, but this is not the long-term medication. You need to make sure that you don't miss systemic diseases that has to be where you have to give steroid-sparing agents. Okay. I think by now I have to conclude because I'm almost reaching my time. Mydriatics and cycloplegics are important to break any synecdoche present. We give, you can alternate atropine and cyclopentolate, and they are safe to be given for a few weeks to break any synecdoche happening on. Non-steroidal anti-inflammatory drugs are very, very useful tools and should be used. Immunosuppressive medications, usually for HLA-related diseases, mycophenolate mofetil, methotrexate, adalimumab is becoming more and more prominent these days. Management, you need to make sure you don't have side effects of medication, intraocular pressure, and development of cataract. In every visit, you must repeat history taking and update new symptoms or signs to comfort or change your diagnosis. Do not be arrogant and stubborn. Patience is your best tool, and history taking and acknowledging new signs is always important to change your approach to the patient. Thank you very much. If you have questions, please send them to me and I will try to write them or answer on the chat box.
السلام عليكم دكتور ساعاتي.
عليكم السلام ورحمة الله.
ضبير قحطاني R2 KKH program. I have one question, Doctor.
تفضلي.
Would it be possible to have two different diagnoses in one patient? For example, if the patient presented with KPs and very high IP in one eye, and the other eye also high but is not as high, with the presentation of post-notch-Rossman in one eye and the uveitic glaucoma in the other eye. First presentation, young patient. We had this scenario and we had like a conflict about it. So it's not clear. Would it be possible? Have you seen any patients with two different diagnoses of uveitis?
I don't think you have mentioned two different diagnoses. So you are sure that in one eye there is Posner and the other eye is just uveitic. I think one of them is wrong.
It could be herpetic. The thing is, it could be herpetic without being Posner.
لا خلاص صار اسمها bilateral herpetic eye disease.
Yeah.
بس واحدة is more severe than the other.
Yes.
But
so if we didn't have KPs, bilateral KPs, we would not.
Not necessarily to be symmetrical presentation.
Yeah.
I mean, again, we're saying 90% of the cases are unilateral, but not 100% are unilateral. So it can be bilateral disease. Being bilateral does not mean symmetrical affection or symmetrical presentation. It can be asymmetrical in severity.
Great.
You might see KPs in one eye and you don't see it in the other eye. Now, this is when we present them, we say most likely this is how they are.
Yes. Thank you, Dr.
If you have more questions, please write them in the chat box because I don't want to take the time of the grand round, okay?
Okay.